We will be talking about a very important procedure in interventional pulmonology by the name of medical thoracoscopy. Thoracoscopy has also been called pleuroscopy because it is basically an examination of the pleural cavity. I think that amongst the procedures in interventional pulmonology, this is perhaps one of the most important procedures because a large number of patients with pulmonary problems suffer from pleural diseases, and amongst the pleural diseases about 20% of them remain undiagnosed if you do not take recourse to a pleuroscopy. So we will be talking about this very important procedure. Let us look at the history of the procedure and how it came about. As I said, thoracoscopy involves the insertion of a rigid or a semi-rigid telescopic device into the pleural cavity to inspect and to take biopsies and to perform therapeutic procedures like pleurodesis, mechanical breakage of adhesions, sympathectomy, pericardial window creation, etc. It may be a medical thoracoscopy through a single port under conscious sedation, or it could be a video assisted thoracoscopy surgery with multiple ports under GA, and we will be talking about the difference between the two. The procedure dates back to the year 1866 when Dr. Samuel Gordon in Ireland first did a thoracoscopy. Subsequently, Jacobius, who is considered the father of thoracoscopy, who was a Swedish internist by the way, put a cystoscope into the pleural cavity and examined it to look for tubercular lesions, and he tried to create an artificial pneumothorax to collapse the lung, as was the want in those days for treatment of tuberculosis. The procedure was then revived by several workers in the 50s and the 60s, but later on it was the pioneers like Astol, P. Astol, Mathur, Bottin and Lodenkamper who eventually actually brought it to its present to its present stage. All of these above use the rigid thoracoscope. We will be talking about another thoracoscope which has now come in, which is the semi-rigid thoracoscope, but more of that later. Now, what is the difference between medical thoracoscopy and VATS or video assisted thoracoscopic surgery? Medical thoracoscopy is done by pulmonologists. It is done under conscious sedation in a bronchoscopy suite. It is done through a single port. It is used for pleural lesions and it is less expensive. While VATS is done by thoracic surgeons, it is done under GA with a double lumen endotracheal tube in the operation theatre. Multiple ports are used and it is used for operating upon the lung, the mediastinum and the pleura. It is obviously more expensive. So medical thoracoscopy has its niche where it is used primarily for diagnostic purposes and can be used under conscious sedation with a single port and used by a pulmonologist, unlike VATS, which is usually done by thoracic surgeons. Now, if you look at the approach to a pleural effusion, you realize that mainly a thoracentesis is what is done first. The usual approach would be to analyze the fluid grossly for the color, turbidity, smell, etc. Some things are obvious, like for example a hemothorax or an empyema, which is apparent from its very the look of the pleural fluid. However, sometimes you need to do a pH, you need to do the triglycerides if the pleural fluid is milky, you need to usually look at the protein, sugar, LDH, ADA, etc. However, despite doing the initial workup that is done for the pleural fluid, there is a significant number of patients where you still do not have a diagnosis. It is in those patients that you consider doing a pleural biopsy. Sometimes, of course, if you have a transurate, a patient with a CHF, a nephrotic syndrome, or a congestive heart failure, you know for sure that you are dealing with that is the reason for the pleural fluid. Sometimes there is a systemic disease, say like SLE, and a patient has bilateral effusion, and you know that it's likely to be because of the SLE. However, there are certain times when you do not have a diagnosis. A typical example would be a lymphocytic exudate with a low ADA and negative for malignant cells. It is in those situations where you are not sure at all what you are dealing with. So it is in those situations you try to take a pleural biopsy. Now conventionally pleural biopsy has been done by a closed pleural biopsy. This was done under local anesthesia. You might remember the Abrams and the Kopf's needle. Mind you, over the last many years now that we have started doing medical thoracoscopy, we have stopped using the closed pleural biopsy altogether. Because when you do start doing thoracoscopy, you realize the amount of advantage that it gives you over a closed pleural biopsy, and we will be talking about that. A pleural biopsy is done blindly with a Abrams or a Kopf's needle. If you have CT guidance, you can do a true cut biopsy, and that has certain advantages over the closed pleural biopsy. However, it is mainly for the diagnosis of tuberculosis and malignancy. Now, the advantage of the medical thoracoscopy over the blind biopsy is that you do a complete examination of the pleural cavity and the lung. Biopsy is taken under direct vision, and it allows for optimal preparation of the pleural surface. Suppose there are adhesions, you can remove those adhesions, and if you want to do a pleurodesis at the same time, you can complete the procedure by doing a pleurodesis before you come out. So it is infinitely, I would say, more advantageous than a closed pleural biopsy. Now, this is an analysis from the British Thoracic Society guidelines of 2010, where they compared cytology, closed pleural biopsy and thoracoscopy, and they found in a pooled data of 1370 cases, that's a large number, 60% positive from malignancy from a single diagnostic aspiration. In mesothelioma, surprisingly, you find that the pleural cytology is only about 30%. For some unknown reasons, the mesotheliomas do not shed the cells into the pleural fluid, and therefore the cytology is even lower. The closed pleural biopsy increased the yield by about 7 to 20% over the cytology. However, still there were about 20% of cases which were not diagnosed by either of these two procedures. Thoracoscopy, and this is an analysis of 23 series, 92% yield in malignancy, 90% in mesothelioma, and 100% in tuberculosis. Now that is an astounding increase over the closed pleural biopsy. So therefore, it is not surprising that most pulmonology programs all over the world today strongly favor their pulmonologist trainees learning the art of medical thoracoscopy. Look at this study, and in this you will find this is a retrospective study of about 150 patients. Medical thoracoscopy was done and it had a sensitivity of 90%, malignancy in 88%, specificity of 96%, and again 100% for tuberculosis. And in a country like ours, where tuberculosis is so common, if you have a tool where you can diagnose your indeterminate pleural effusion with confidence, especially for tuberculosis, it is a big advantage. And this study also showed a very low morbidity with the medical thoracoscopy. Hardly 0.6% patients suffered from complications like empyema, pleurocutaneous fistula, transcutaneous growth of the tumor, etc. So a very low complication rate. So it is not only an efficacious procedure, it is also a very safe procedure. Now look at this. What are the training requirements for medical thoracoscopy? How difficult is it to learn medical thoracoscopy? I can tell you from personal experience and from experience of a large number of people who have learned medical thoracoscopy over the last decade in India, that is actually quite simple. All you require is a knowledge of the pleural and thoracic anatomy, ability to interpret radiographic images related to pleural diseases, and this is a part of training of all pulmonologists, sufficient surgical skills. I remember the first workshop where I went to, when I was asked to learn medical thoracoscopy, the person who was teaching us asked us how many of these people in the room know how to put an intercostal tube. Everybody put up their hands. He said if you can if you can do an intercostal tube blindly, you can do a guided intercostal tube. That is what thoracoscopy is. So it's actually a very, very simple procedure. You need to perform at least 20 procedures in supervised setting to establish basic competency, and to maintain competency should perform about 10 procedures a year. So the training requirements are actually not very difficult, and the learning curve is not very steep. What are the indications now for medical thoracoscopy? When would you want to do it? the large majority of patients would be indeterminate pleural fluid. So you have a pleural fluid, as I said, you do not know its nature, what is the cause, and therefore you want to do a thoracoscopy. Abnormal pleura, if your CT or your imaging is showing you an abnormal pleura, you may want to sample that by doing a thoracoscopy. There are few people who are taking biopsies from the lung in diffuse lung disease by doing a thoracoscopy. I would not advise you to start off this immediately as you start doing thoracoscopy, but as you gain experience with the help of a harmonic forceps biopsy or a hot forceps biopsy, you can take biopsies from the lung surface. I would strongly recommend that you should have at least 100 to 150 thoracoscopies under your belt before you start tackling the lung. Primarily, initially, you should tackle only the pleura. Then therapeutic indications are a pleurodesis. As I said, you can do it in the same sitting. You can also do it in patients with empyema, parapneumonic effusions, where the thoracoscopy can be done to completely remove all the debris inside the pleural cavity, remove the large adhesions which are there, make it all of it a single cavity by doing a good debridement, and then putting an intercostal tube in the correct place so that the drainage can be facilitated. And it works very well, and there are papers in the literature to show that in empyema, lots of people are now doing medical thoracoscopy in the initial stages. Pneumothorax, yes, it can be done in pneumothorax. One, to look at the lung surface, if there are any small bullae, they can be cauterized, and at the same sitting, a talc powderage can be done over the thoracic, the pleural cavity to get a uniform spray of talc all over the pleura so that an effective pleurodesis can be done. And then finally, if you have more experience with thoracoscopy, procedures like sympathectomy and creation of a pleuropericardial window have also been done by expert thoracoscopists. What are the contraindications for medical thoracoscopy? You can imagine that if the pleural surfaces are adherent to each other, you cannot perform a thoracoscopy because the visceral and the parietal pleura must be separated. There must be space between them to move. Only then you can do a thoracoscopic procedure. So lack of a pleural space is a contraindication. Of course, if there is uncorrected coagulopathy, hemodynamic instability or respiratory failure, then the patient cannot be taken, because mind you, when you are entering the pleura, automatically a pneumothorax is being created. And when that happens, the lung is partially collapsing. So the patient should be able to tolerate the collapse of one lung, and that is the time when you can do a pleuroscopy. Now, what is the instrument like? Now, this is on your screen. You can see that this is the rigid thoracoscope. Here at the bottom of this assembly, you can see this is the telescopic device. This is the rigid thoracoscope. This is the trocar and the cannula for inserting. This pump below is the pump for the powderage, and then above you have the different type of forceps which are there. And mind you, all these forceps are cautery enabled. So while you are doing the procedure, you can also do a cautery if there is bleeding. And besides this, of course, you need a xenon light source, you need a camera, you need a monitor and a recording device. Most good operation theatres would be having this for their laparoscopic work. The semi-rigid thoracoscope. Now, this is a new thing which has come about in the last 8 or 9 years, and the first papers came out in 2007, where an autoclavable semi-rigid thoracoscope was, and this is the picture which is showing that. It has a shaft which is rigid, and the proximal part is rigid, and the distal part bends just like a bronchoscope. So if you are already used to doing bronchoscopy, the handling of this scope is just like a bronchoscope, like a flexible or a video bronchoscope. And therefore, the learning of this is much simpler. It is also, because of its smaller size, less chance of being traumatic, and you can get biopsies which are as good as the rigid thoracoscope. It is, however, not as good for the therapeutic procedures like breaking adhesions, say for example in a patient with empyema, or for the more sophisticated procedures like sympathectomy, etc. So primarily a diagnostic tool, a semi-rigid thoracoscope, and these are papers to show how the diagnostic accuracy of semi-rigid thoracoscope is almost same as the rigid thoracoscope. So these people have shown that the samples obtained by semi-rigid thoracoscopy were smaller but of adequate quality, and this is a meta-analysis from our friends in the PGI who have shown that semi-rigid thoracoscopy is an efficacious and safe procedure in the diagnosis of exudative pleural effusion. Now, the usual workup that you do for a patient with thoracoscopy is that a chest radiograph is taken. It would look something like this picture here, which is showing a large pleural effusion. You may take a lateral decubitus film if you feel that the fluid is not much. An ultrasound is invaluable. An ultrasound procedure must be done in all patients where thoracoscopy is to be contemplated. Reason being that the ultrasound shows you exactly which is the port of entry for your trocar. So the usual thing would be to take the patient to the ultrasound or have an ultrasound in your operation theatre, put the patient in the non-dependent position, that means the affected side up, then do an ultrasound in the lateral decubitus position, find out an intercostal space which is about couple of spaces above the diaphragm where there is fluid, preferably in the mid-axillary line, and mark that, because that is the position that is going to be there on the operation table in which you are going to take the patient for medical thoracoscopy. So as I said, of course you will do if you have a CT scan, that is very beneficial. ECG and a coagulation profile of course must be done. Now the usual step will be an ultrasound guide localization. As I said, put the patient in the lateral decubitus position with the axilla fully exposed, mark the site of entry. Now mind you, thoracoscopy, although you may be doing it in your bronchoscopy suite, it is an operative procedure where you are entering the pleural cavity. Strict asepsis has to be ensured. You cannot take the procedure lightly only because you are doing it in the bronchoscopy suite. So all surgical aseptic precautions must be undertaken, right from the scrubbing of the surgeons to the draping and cleaning of the patient before the patient is taken up for the thoracoscopy. This is utmost important. Then after you have prepared the skin, local anesthesia is given with 2% xylocaine, just like you do for intercostal tube. Usually you will give sedation. Sedation may be a mixture of midazolam along with fentanyl, or you could use propofol, whatever you are comfortable with. It's a good idea in your team of 2 or 3 people to make one person in charge of the sedation and the monitoring of the patient, while the other 2 people handle the procedure itself. And you could rotate amongst yourselves so that everybody get a chance to do the procedure. But always try to keep one person in your team who is handling the sedation and the monitoring of the patient. Now, so this you can see the patient has been draped, and aspiration must be done to make sure that there is free fluid in the space that you have entered. Free fluid is important because that means that shows that the pleural surfaces are separate and there is fluid there. Sometimes you may ask that suppose the pleural fluid amount is not much, how will you do a thoracoscopy? You can still do a thoracoscopy by taking the procedure first, the patient first to your radiology area, under ultrasound guidance, putting in a needle into that small pleural space that is there with a little bit of fluid, and then injecting air. You can inject about 500 or 700 ml of air, create a pneumothorax before you take the patient onto the table. So what we do there is inject the air, take an X-ray to see that the lung has collapsed and there is even collapse of the lung and there is separation of the pleura, and then take the patient for thoracoscopy, and then you can do thoracoscopy even in a patient who has minimal effusion. So you then proceed in the usual manner as you do for an intercostal tube by doing blunt dissection. You can see here a blunt dissection being done with a forceps. The same forceps can be used then to puncture the pleural space. You will feel a give of resistance as the forceps goes through, and then when you are coming out, you open the forceps and then come out. That way you create a hole in the pleural cavity. Once that hole is created, you can see here the surgeon here is, yes, so he has forced the thing inside, and this is an innovation that we use in our center. The Heger dilators, which are used by our gynecologist colleagues for cervical dilatation, we use sequential dilatation with the Heger dilator to get a smooth dilatation of the place where we are going to put the trocar. So after the dilatation has been done, we put the thoracoscope inside. This is the full assembly of the thoracoscope which can go inside, and you can see here the distal part, the trocar and the cannula, and then the thoracoscope with the telescopic device. And now once the the trocar and cannula have been inserted, many times you find that the pleural fluid is under positive pressure. You have to wait for the pleural fluid to be evacuated first. This you could do by actively suctioning it out, or if it is under a lot of pressure, you can actually just collect it in a kidney tray as it flows out. Now once that is done, you can see here that the pleural cavity is then exposed, and once the fluid has been drained out, sometimes people ask how much fluid can you drain out? Successfully you can drain out 2 to 3 liters of fluid. Why these patients do not go into a pulmonary edema is because pneumothorax is being created at the same time. You can see here a brilliant view of the pleura once the pleural fluid has been taken out. This is the diaphragm on one side, this is the parietal pleura on the other side, and you can see here these nodules on the pleural surface. And once you have seen this kind of picture, you forget about closed pleural biopsies, because these, when you are taking biopsies, large chunks, no pathologist is going to complain of poor specimen or muscle or collagen that you get with closed pleural biopsies. So you can actually pluck out these nodules under direct vision with your forceps biopsy. So this is the kind of view that you get with the thoracoscopic procedure, and that is why it is now come to stay, and that is sort of mark the death knell for closed pleural biopsies. And once you are done with the procedure, then you can actually spray the talc. Now here a chemical pleurodesis is being done by spraying asbestos free talc. About 4 grams is used. It should be a high grade talc, because it was seen earlier that with finely graded talc, patients started to develop ARDS in America. But the Europeans showed that if you are using a talc which is of a higher grade, that means of a coarser grade, then there is no question of any ARDS. And you can see here, this is a snowstorm appearance because of the spray of talc all over the pleura, and the costal pleura, the diaphragmatic pleura, the mediastinal pleura, all of it can be coated nicely with the talc, and about 4 grams of talc is sufficient for this purpose. Now once that is done, the tube can be placed. So the other big advantage of thoracoscopy is that you can actually put your intercostal tube right into that posterior gutter where it should be, and the pleural tube is put there and connected to a water seal. Now what are the risks of this procedure? There can be bleeding, there can be subcutaneous emphysema, infection of the pleural space can occur. So that is why it is very important that you must treat it like a surgical procedure. Injury to the intrathoracic organs if you are not careful, so you may actually injure the lung while trying to go around the lung. Atelectasis, that means the lung does not expand because of an air leak, and respiratory failure. But mind you, all these complications are actually quite uncommon. What is the sclerosing agent to be used? As I said, talc is the most effective sclerosing agent, but many others like bleomycin, doxycycline, povidone iodine, quinacrine, Corynebacterium parvum, etc. have been used. But talc has the maximum efficacy. High grade asbestos free talc is insufflated into the pleural cavity so that it is spread evenly over the surface. Pleuritic pain and fever are the most common side effects of sclerosin. Sometimes ARDS has been reported, as I said. Negative suction can be applied on the ICD if you are not getting good expansion of the lung. Now what has been our experience, and this is just a slide to show you that in about 98 patients, all patients who had exudative effusions of indeterminate cause, the procedure was unsuccessful in only 1, which makes a efficacy or a yield of almost 97%. Diagnosis: adenocarcinoma in 58, lymphoma in 4, malignancies in 4, TB in 19, etc. Talc insufflation was done successfully in 62 patients. And look at the bottom there, surgical emphysema in 4, persistent air leak in 2, minor bleeding in 4, 1 death 3 days after the procedure because of other causes. So pretty safe procedure. Let us look at some cases. This is a 66-year-old recurrent pleural effusion, chest pain and dyspnea for 2 months, pleural effusion, negative cytology, mind you, negative cytology, high LDH, low ADA. The pleural biopsy shows malignant mesothelium. You can see here that despite the pleura being completely studded with nodules, still the pleural fluid cytology is negative. Now this shows you how mesothelioma especially can fool you if you rely on pleural cytology, pleural fluid cytology alone. Another case, this is a 36-year-old lady, carcinoma breast with recurrence, obviously a high chance of disease there in the pleura, pleural effusion refilling after repeated thoracentesis, pleural fluid lymphocytic exudate, negative cytology, biopsies taken through the thoracoscope show metastatic carcinoma. You can see here the pleura completely studded with nodules, yet the pleural fluid cytology negative. And so biopsies were taken and then a talc pleurodesis was done. Another case, 59-year-old, bilateral pleural effusion, fever, chest pain, also had pericardial effusion. Pleural fluid lymphocytic exudate with normal ADA. Now look at this pleura, it is actually looking quite normal, but you see these small nodules? Now if you think, and these pleural nodules came out to be caseating granulomas with occasional AFP, but you can imagine that if one tries to pick these nodules with a closed pleural biopsy, it is like finding a needle in a haystack. There is actually no hope that you can actually pick up this kind of a small nodule in the pleura with a closed pleural biopsy. There is every likelihood that you are going to miss it on a closed pleural biopsy. Another case, 80-year-old, right side pleural effusion, hypertension, dyspnea, no fever, pleural fluid cytology negative, lymphocytic exudate, high LDH, normal ADA, pleural biopsies, multiple caseating granulomas. So when you have this kind of studying of the pleura with a lot of small nodules, sago nodules, then you may think that closed pleural biopsy also could have got your diagnosis. There. So you can see here studded with small nodules, and of course this showed TB. Right. Now I come to my last slide, which is the concluding slide, and these are my concluding comments. Medical thoracoscopy, pleuroscopy is a minimally invasive procedure with superb yield. It has the advantage of being performed under local anesthesia with sedation. It can be used effectively for therapeutic procedures like pleurodesis, breakage of adhesions, and proper placement of chest tubes. The success of the procedure depends on proper selection of the cases and ruling out those cases or excluding those cases where the pleural surfaces are adherent. It is a safe procedure with minimal complications. Both the rigid and the semi-rigid thoracoscope are excellent tools for this procedure and could be used to complement each other. Just like bronchoscopy, where we have started using both the fiber optic and the rigid scope together. In interventions, you can't do without both of them. Similarly, a time may come when we start using both the rigid as well as the semi-rigid thoracoscope for our cases. And training which is required is simple and easy to learn. Thank you very much.